All right. Well, hello, everyone. My name is KIRK Garratt from Christiana Care in Wilmington, Delaware. I'm joined by Cindy GRINES. The two of us will be co-moderating this session today. Welcome. We're really pleased to have you. This session this evening is entitled Cath Labs Now, Navigating Today's Realities and Beyond, and we're pleased to have the opportunity to join you tonight to talk about some important issues. We've learned a lot in the last 12 months, and one of the things we've learned about is the importance of providing equitable care. So I'm delighted to have a chance to hear from experts in our field that have a particular interest in assuring that we provide care equitably and address the needs of our most vulnerable populations. You'll be hearing tonight from several esteemed speakers, including Wayne Batchelor from Inova Fairfax Hospital, FOLUSO FAKOREDE from CV Solutions of Central Mississippi. I've already introduced Dr. Cindy GRINES from Northside Hospital, and ROXANA MEHRAN from the Icahn School of Medicine at Mount Sinai in New York. Before we begin, we have a few housekeeping items to take care of. First, I want to just remind everybody that we will be going through a series of lectures one at a time. There will be a bit of time at the end of each for questions of the speakers, and we've also tried to partition time at the end of this hour to have a more global conversation. So please keep your pencils sharp and your paper handy. Write down questions as speakers are making their comments and be ready to engage. As you can see, we have some really great territory to cover in the agenda tonight. Looking forward to getting started. And now I'm going to turn the podium over to Dr. Cindy GRINES, our first speaker for this evening. Cindy, I think you're going to be talking to us about how seconds still count and a little bit about what we've learned from our NACMI registry. I'll turn it over to you now.
Okay, well, thank you, KIRK. Welcome to this very interesting SCAI webinar. I'm going to discuss what SCAI is doing to discuss treatment avoidance and disparities related to COVID-19. First of all, I want to say that health equity matters. We at SCAI are committed to reducing treatment disparities in coronary, peripheral, structural, and congenital heart disease, as well as assuring that we have adequate, diverse representation on our SCAI committees. With regard to COVID, we are well aware of the avoidance of care that started in the spring of this year, resulting in a drop in emergency room visits of about 50%, a drop in non-COVID hospitalizations of similar 50%, and reduction in STEMI admissions of 40%. This has resulted in those patients who do come to the hospital with MI, they arrive very late with these delayed presentations causing more severe LV dysfunction, cardiogenic shock, as well as more mechanical defects. With knowledge of this, we've actually come out with several white papers on the management, and we also developed SCAI's second. As part of this, we sent out a consumer survey and enrolled more than 1,000 subjects. And what we found is that 50% of the people in the community are more afraid of contracting COVID in the hospital than of dying from a heart attack. And they were more fearful of going to the hospital than, say, going to the theater or a hair salon. And so because of this, we decided to try to come up with a media campaign. And we developed this patient awareness campaign called Seconds Still Count. This is the purpose is to message patients at risk, partnering with other patient support organizations, and developing a hospital toolkit for effective communications. There was enormous media presence, and KIRK was interviewed for multiple news networks, and this was picked up in more than 2,000 media outlets, including radio, TV, and the print press, including USA Today and CNN. So it was wildly successful. We're doing what we can to help bring more patients into the hospital. I think all of us have seen there is an uptick in patients coming back to our catheterization laboratories and hopefully improvement in prognosis. Now, moving on to the NACMI registry, NACMI stands for North American COVID MI Registry. And what this is a registry that SCAI has put on in conjunction with some assistance from ACC. And we developed this registry of patients who have ST segment elevation to try to figure out how they're being managed and what their outcomes are. Tim Henry reported our initial results at TCT just a month ago. And in that, we had enrolled about 600 patients, of which nearly 200 had confirmed COVID with ST elevation. The remainder of the patients were considered patients under investigation. What we found is the majority of those patients, more than 50% of them, were either Black or Hispanic. And interestingly enough, even though there was some talk about treating patients with thrombolytic therapy early in the COVID era, about 70% of these patients were treated with primary PCI, and the use of thrombolytic therapy was only a few percent. So that's good news. Our guidelines have seemed to have made a difference. And then interestingly enough, if you look at the mortality in these individuals, it was about 30% mortality in those COVID positive patients who presented with MI. And that sounds like it's very high, but compared to what was previously reported from some of the publications in New York City, this is much better compared to their 80% mortality. So we're still enrolling and would encourage all of you to try to participate in this very, very important registry. And then I just wanted to briefly talk about the American Heart Association. Just last week presented some of their information from the COVID registry. And this is a registry of all COVID positive patients, not just patients with cardiovascular disease. What they found again is that there was a lot of cardiovascular risk factors in patients who were hospitalized with COVID. The highest, of course, being hypertension, followed by obesity, followed by diabetes. And again, I think about 58% of these patients that were hospitalized with COVID were either Black or Hispanic. The good news is that surprisingly, less than 10% of those patients who died of cardiovascular reasons. The majority of deaths were due to respiratory reasons. And when they broke that down into race, it did not appear that Blacks or Hispanics died more frequently with COVID compared to whites. But the overall number, of course, was higher just because there are more individuals of Black and Hispanic race who were admitted. So there's good news on the horizon with adequate treatments, as well as some good promising data on vaccines in the very near future. Thank you very much.
Yeah, that's terrific, Cindy. Thanks a lot. You know, it is really a painful thing to see across the country. COVID-19 blowing up again. It looks like a younger population being afflicted this time around. But from what I can glean, it sounds like the racial and ethnic distribution of infections hasn't changed that much. I don't know if any of our speakers have seen anything to the contrary. It does raise a question in my mind about whether we're doing enough to get out ahead of this infection, not just globally, but particularly in those communities where most vulnerable populations live. I don't know if you have any thoughts about that, Cindy.
Well, we certainly need to do something, but you know, it's hard to know where to start. The data from the American Heart showed that those individuals who were hospitalized, who were Black or Hispanic, of course, had lower levels of education, lower incomes. They were less likely to be insured. And so I think that the living conditions are probably quite different compared to what you or I would have. And so it goes back to just basic societal issues as well as education. And I don't know whether we can achieve that at the school, because a lot of schools are not even in session now, or whether, and same thing with the churches. I mean, the way to target those individuals is quite challenging.
Yeah, you wonder about provision of services too. You think about SCAI as an organization, and we have a reasonably narrow focus, and it's not immediately clear how an organization like SCAI would easily get ahead of this kind of a problem. On the other hand, when we see that there's not an equal delivery of services to all the different populations we serve, it does strike me that might be an opportunity for us as a community of interventional providers to step toward, but also for agencies like SCAI to have a position on and to facilitate solutions for addressing those equity gaps. Does that sound right to you, Cindy, as you know, chief executive in the organization? What are your thoughts?
Yeah. So, you couldn't have put it better, Kirk. I mean, we, before actually any of this started, as part of my opening speech to get into, when I became president of SCAI, I did address the disparities issue. And this was before there was all this racial conflict, because I recognize that SCAI is, I was only the third woman to be president in the entire time that SCAI's been in existence. So, obviously I'm a minority as it comes to, interventional cardiology. And then if you look at the Native Americans, the Blacks, Hispanics, I mean, there's very, very few physicians, let alone cardiologists. And so we are developing this diversity committee to try to address this. I mean, I don't really know exactly what to do. And so that's why I want to put the most brilliant heads together to address it. And then each of the clinical councils has been charged with trying to look specifically at diversity with regard to how it affects their patients. So if racial diversity and sex diversity, how it affects their patients and the outcomes in that particular category. And I think we're going to hear a little bit about that peripheral disease and amputation. So look forward to that session.
Yeah, great. Well said, as always. And yeah, we've got a lot of work ahead of us. And with COVID-19 resurging here, boy, no time like this immediate moment to be stepping into that gap. So thanks so much, Cindy, for your comments, and as always, for the support you show for the organization. Okay, we'll move on to our next speaker, and I'm so thrilled to see that ROXANA MEHRAN has been able to join us. ROXANA, welcome.
Hi there. I'm sorry, I was just on another webinar since we all moved from Zoom to Zoom and Shazoom. Here I am. I'm so thrilled to see all my colleagues, my friends, our wonderful chief executive at SCAI. I love it. Cindy, you're an amazing chief. And thank you, Kirk, for putting this program so very important, especially now, given what we know. Whether it's this infection, disparities of care didn't just come yesterday. We're just now being made aware of it, and it's vividly in our faces when we see the results of COVID, but also our inability to attract our talented, underrepresented minorities to the field of cardiology and interventional cardiology specifically. I mean, this panel made up of 2 Black men and 2 women is not representative of SCAI leadership or SCAI membership at large, but so very vibrant to know that this society cares. It is the home for all interventional cardiologists across the globe. It has always been inviting. And I can say that for me personally, this was the society that took on the Women in Innovation idea that I had to heart and made it, put it in front of the stage and let it shine. And it's now all over the world. And I'm just so proud to serve SCAI and to be part of the membership and also previous leadership, and look forward to continue to work with SCAI, and especially with our president, who's so incredible and driven to get away from all sorts of disparities, whether it's in sex or race. And so it's great that you put this program, and thanks for having me.
Well, ROXANA, we couldn't be happier to have you with us in the fold. And we're looking forward to hearing your thoughts about historical disparities across the care continuum.
I know that you didn't want slides, but I did.
Well, that's okay.
Sometimes a picture is worth 1,000 words. So bear with me, and I will not take very long. But here's what the truth is. The US white majority will soon disappear forever, ladies and gentlemen. Note this and make sure that our healthcare providers are going to mirror the population that they serve. And by 2050, the US will be a majority minority country with white non-Hispanics making up less than half of the total population. I think this is really, really important. And this is the census where the whites are declining, non-white majorities increasing, especially amongst young Americans. And more than ever before, we need to erase racism and sexism across the board. And when we look at the deaths, avoidable deaths from cardiovascular disease, and when you age adjust this, you're seeing the non-Hispanic Black males with the highest deaths per 100,000. And it's really the, and you can see it, the racism really there in understanding these are avoidable deaths from heart disease, stroke, and hypertensive disease. Deaths occurring in persons aged less than 75 years with an underlying cause of ischemic heart disease, cerebral vascular disease, hypertensive disease, and chronic rheumatic heart disease. And a lot of it also has to do that our treatments are very much dependent on our clinical trials that helps then guide how we treat our patients. And the disparities in the enrollment in these cardiovascular trials are really not helping us in gaining the evidence we need for the underrepresented minorities and women. And so I think this is really one of the biggest things that we absolutely must get around. The percentage of men and women participating in diabetes and cardiovascular trials according to the years of approval are here. You can see it's mostly dominated by men, and over time we're starting to see year of drug approval and trying to get some change, where in 2017 we're trying to get to a better place with, especially with these drug trials. But the percentages of white and blacks enrolled in pivotal cardiovascular and diabetes trials, as you see here, according to the years, you see the numbers of whites and black racial participation and the year of approval, and constantly seeing that the black population is poorly seen in these trials. So COVID disparities, we talked about this, the vulnerable population, the poor outcomes that's related to this, and very, very much the need for equitable government and public health oversight. We can't underestimate how important this is. We're seeing this in COVID-19, but especially in cardiovascular disease as well, and understanding that this virus does have an important impact on the heart, and how we can get to the bottom of this is incredibly important. And then, of course, this whole idea of the social determinants of health is not sometimes just related to the color of your skin or your gender, but also to your zip code of where you live, and what socioeconomic status you have, and what kinds of access to care do you have. And this has been a very, very big determinant in outcomes in COVID. And we do know that it does have a very important implication for cardiovascular health, as well as even interventional treatments. And we've seen this in the past 100%. I want to talk a little bit about what went on in New York City when where we, the data in the New York City Department for COVID disparities of the health data found that over 2/3 of the 30 zip codes with the highest per capita rates of testing were homes to higher proportion of white and wealthy individuals than the rest of the population. I'm shameful of that in my city. And it's really has to be the catastrophic outcome of this disparity when you're seeing that the African-American individuals have a 30 to 60% higher incidence of thromboembolism compared to the white individuals. And this could be related to the increased susceptibility to endothelial injury, hypercoagulability, higher rates of obesity, and chronic inflammation. And then, of course, the final common pathway is the catastrophic thromboembolic events that's more likely in Black individuals than in whites. And there is no one better than Clyde Yancey, who talks about when social distancing becomes a privilege. In certain communities where the population is dense, instead of a home built for 2 or 4, there are 6, 8, or 10 people living there. Just the feasibility of social distancing is beyond anything that is possible for these individuals who are living in these conditions. And you have a circumstance in which the one community that already is beset with social determinants of health and have other diseases that put them at risk are unable, because of their living circumstances, to actually exercise social distancing. So this is a very, very in-depth discussion. And I think that the fact that we are bringing it out and discussing it openly, KIRK, and talking about how we as individuals could actually help mitigate those important differences, because we can't overnight at SCAI change the living situation or the social determinants of health or the zip codes that our underrepresented minorities are living in. You know, we don't talk about our Black women and their outcomes. They're also, not only are they burdened by what's going on with the virus and most likely the later events and occurrences of inflammation and other things that could happen, they're also burdened by having to take care of their families. Most are single moms. Their children are young. They're all, and the public schools just closed, you know, and especially here in New York City, where we are just driven by teachers' unions. Our mayor is closed the schools on November 19th, when gyms and restaurants are open, which makes absolutely no sense, because you're really just increasing the burden on those families that cannot be in the private school setting where they're of course being catered to. So there is just so much that we need to deal with. And when you see that a society like SCAI is paying attention to this and bringing it to the forefront, and the NACMI registry that Cindy spoke about, where 50% of the population that's getting treated with a STEMI are Blacks or Hispanics, and that their outcomes is actually worse, is very, very important for us to pay attention to this and to figure out a way that there's equitable care, access to the best devices and the best that we can offer. And certainly as interventionalists, our job in making sure that we are working hard to not have a TVT registry that has 95% white individuals, but rather understanding that aortic stenosis also exists in the population of our Hispanic and Black Americans. So there's a lot to talk about, KIRK, but this is a very deep history that has been around. It's not just COVID, but I think COVID kind of bursts the pimple, right? And we're kind of just seeing the wound is there and the scab has been removed, and now we are really seeing the results. And the idea is not to put a Band-Aid over that wound, but to get to the underlying causes and try to make a difference as a group. And I'm just so proud that SCAI is working towards that.
Well, thank you. Thanks for those incredibly insightful comments, Roxana, as always. And while you were speaking, I got a text from Drew Klein, who commented that this is a great webinar, but he worries that we as an organization need to be actively building trust by enrolling more minority members to assure that we're not just giving signals, but we're actually doing the right things. And I'm sure you would agree with that.
Absolutely, but I can tell you that it's really hard to identify interventional cardiologists who are Black and Hispanic and Native American, and that's one of the reasons we developed this diversity committee to make an attempt to, just by, the grassroots effort to see if we could get more individuals interested in SCAI and involved in committees. So we're doing what we can. We actually tried to partner with ABC as well. It's just that ABC is, they have a lot of work on their plate as well. So we haven't gotten too far along in that regard. But hopefully, Wayne, you can comment on that, because I think you're actually on the diversity committee.
Yeah, no, I think you've hit the nail on the head. I mean, we all understand where we want to be. It's just the question is, how do we get from where we are to better representation? And to me, I think it's, all the societies, we need to think about how we can actually take a stock and somehow come up with good lists of interventional cardiologists across the entire country who may not belong to specific organizations. ABC's done some work in that regard, but it's not easy. You actually have to reach out very far and wide, and FOLUSO may have some other ideas, but there are ways to do it, and then keeping such a list up to date and contemporary would be challenging as well. But I think that the take-home message is our voice as interventional cardiologists is through SCAI and other professional organizations. And we have got to get it out to all of the members of our interventional community that joining this organization or a similar organization that's going to represent our voice is crucial, so that you're not having to do the homework, Cindy, to figure out where everyone is, but there's just upfront voluntary SCAI membership that's occurring across the board. And that's the message that should go out from coast to coast.
Mm-hmm.
Terrific, Wayne. Thanks for that, and really couldn't agree more strongly. I think we'll continue on now to try to stay with the agenda and ask FOLUSO FAKOREDE to make some comments about lower extremity issues, shifting now to a more discrete focus. And FOLUSO, I know you've got some incredible data here that I think is really going to drive home the point that we've got real work to do. You can take it away.
Well, good evening, everyone, and thank you for the privilege of invitation. I'm honored to share the stage with trailblazers. Roxana and Sydney have created a platform not only for women in the field of cardiology, but also for minorities in the field, because they've given us the exemplary profile and courage, but also an excellence. And so I'm honored to share the stage tonight with you, and also to have a mentor in Wayne, who is a fellow ABC member, and as a PhD co-chair for the Association of Black Cardiology as well. I'm honored to share some of my data and how I ended up here in Cleveland, Mississippi, the heart of the Mississippi Delta. So just a little background. Peripheral arterial disease is the most prevalent, deadly, and debilitating and costly pandemic that most people just haven't heard of. We know the data, we know the numbers, but the issues is diabesity. If you look at the map, you have 80% chance of becoming a diabetic just by being an African American compared to your white counterpart. We have these states that have had large burdens in terms of the burden of health from 1990 to 2017. If you look at all the publications and recent JAMA articles, you'll notice that all these states have ranked top 1 to 3 in terms of the high rates of cardiovascular disease and outcomes, morbidity and mortality, but also in disability of activity of living years. But what was shocking in Mississippi is that it's not only is Mississippi 40% of the state actually are African Americans, which is the largest of any state in the country, but it's the only state where every county represented the 15-state diabetes belt. If you look at the belt in terms of those numbers, the prevalence of those numbers to qualify based on those studies that came out were over 11%. And here in Mississippi, that number is above that average, which is shocking. So a kid that's born today in the state of Mississippi has a 65 to 7% chance of becoming a diabetic just by being a minority in any of these counties. In the next 2 decades, African Americans will have the highest rates of cardiovascular disease. But what's more shocking is that if you follow the Black Census Scope of America and you look at the Southern Belt and you look at the amputation rates per state in Medicare patients, and you also overlap that with the lowest number of revascularization rates in America, you see a common trend. Those states are mainly of African Americans and low socioeconomic communities. These patients do suffer disproportionately when it comes to their outcomes from PAD. And we call that the amputation lottery. So your chances of losing your limb is 3 times higher if you're Black and 75% higher if you're Latinx. But where you live, as Roxana mentioned, in terms of your zip code, does play a factor. Your race does play a factor. Your age, meaning if you're over the age of 70, if you're a female, if you live in a region where your hospital has a low vascular intensity level in terms of volume, and if you're poor. And hospital-related costs account for majority of the total cost. Medicaid and Medicare patients will undergo an amputation before someone who has commercial insurance. And who pays that bill are we taxpayers. We bear the burden of that $30 billion major amputation cost and an additional $20 billion minor amputation cost, not to mention the cost of the family members. And unfortunately, the risk factors are more prevalent in our Hispanic populations. We present more with severe ischemia. We present more with comorbidities. And independently, we're just at risk for major amputation. And social determinants of health has a role to play in this, but also we have to look at the social context. And that's what we see now in the context of COVID, that just unblinded this intergenerational dehumanization of these patients with a deadly outcome if you look at their mortality rates, which are higher than strokes and most cancers. However, one of the lowest awareness rates. So the lack of education is a big piece to this on a patient level, provider level, and also the community level. And so when I moved here 5 years ago, the key was to engage into the community. You know, as an African-American interventional cardiologist, who also is a limb salvage specialist, I represent less than 1% of the medical community, right? And so you come into a place like Mississippi, Delta, with a long historical ties to racism. My office is literally 30 miles from where Emmett Till was murdered. And so this community has had a long history of mistrust in the medical community and the medical field. So how do you bridge that gap? Well, you have to engage yourself and explain things on their literacy level, on their linguistic level, but also you have to engender the trust of these patients so that they can facilitate care-seeking behavior. And so it's all about initiating preventative strategies, but also screening these patients on time, knowing that you can decrease their odds of having an amputation, which we effectively did over a 3-year course and decreased amputation rates by 88%. So I do believe that going into underserved community with an emphasis on population screening and education awareness is key, just as we did in this patient population in 2017. Despite the US Preventive Service Task Force telling us not to screen for asymptomatic patients, a patient who's had a CVA and a diabetic for 40 years, this is a military wife who lived in Virginia and moved back to the Delta. She didn't have any pain, but her legs always gave out on her. So we screened her and she had a high osteo SFA lesion. And 2 weeks later, she's up in my office and she's standing. And so when we tell these patients to come into your office or you see them in the hospital settings, what's shocking here is that most of these patients have just never had anyone take off their socks. And when you take off their socks, you see pictures that are just chilling because they just didn't understand that their feet turning black all along was just due to poor circulation that was just not picked up by their primary care docs who are just not informed on what the disease state is. And so we also have no incentivization for those primary care docs to screen for these patients because their body does not recommend that. And so we end up with this picture, which is sad. It's a sad picture because 90% of these patients never had an angiogram before an amputation. And if you look at the commentary recognizes these well-established disparities in care. However, screening and treatment in these groups are currently lacking, and we're unable to determine the overall benefits and harms, and future research should include diverse populations and report their outcomes. Well, that's nice to print on paper, but when you come to a community like this, you know, and you look at historically, I credit Wayne for this because Wayne shared this slide at a conference a couple years ago. The underrepresentation and the lack of representation of African Americans in our trials has just been abysmal. That's been heralded and mentioned by Roxana earlier. Look at this Hispanic population. Look at our women. Look at the elderly population. We have failed. Our whole system has failed. So we need to now go and rectify years of intergenerational gaps in terms of delivery of care. And how do we do that as a society? It's challenging. And so getting involved in policy with some of my fellow SCAI members and ABC members was something that I prided myself and my teammates in getting involved in establishment of the PAD caucus, which is basically one to not only get our congressional members informed about what's going on in the community, but to see how we can affect education, research, and treatments and in outcomes. And we did that by just amplifying the megaphone, publicizing. And you know, it's a bipartisan effort that has led to introduction of policy to say we need an amputation reduction and compassion act that basically looks at screening at-risk patients based on ACCHA guidelines and have all members covered, and trying to incentivize amputations that are performed non-emergently without an appropriate vascular screening. It's that simple. You know what we call that compassion, because that's what it is. If your mom or my mom or your brother or sister had risk factors for peripheral arterial disease, these patients should be given the appropriate timely screening and effective treatment strategy, medically first, which is underutilized. And then if they need an intervention, that should be appropriately done. And the best route in terms of, you know, minimally invasive versus surgical, that too can be debated. But the whole point is that you want these patients to live longer. 80% of them will be dead within 5 years of an amputation. And they're already at disproportionately affected due to the fact that 70 to 80% of all cardiovascular deaths occur in low to middle income families. So these patients are already disproportionately affected. And so we need to hopefully inform them so that they can transform and live longer and be able to enroll these patients in clinical trials by engaging both on the community level, but also stakeholders in teaching them how we need to go and engender the trust and gain back the trust of these disproportionate and disenfranchised communities. So that's the talk in a sense as to, you know, why it's important for us to have sessions like this to further discuss and let's see, and also to bring back home the whole notion that for us to really bridge the gap in health disparities, I think social determinants of health has to be on the table. I think we need to go back and discuss how we engage our minority students, not only in colleges, medical schools, because we have a low matriculation of minority men, African-American men into medicine. So you're not gonna see a lot of more Dr. Batchelor and Dr. FAKOREDEs and entering into the SCAI membership if you're not accelerating that pipeline. So we need to commit into those programs early on and form some kind of a channel where we can bridge that entry and incentivize them to look into the fields like interventional cardiology or general cardiology.
So, FOLUSO, let me just ask you a question. We're going to be short on time, but I want to be sure to get this on the table. Drew Klein had asked a question earlier touching on the trust issue. You mentioned that a moment ago, and you talked about the importance of recruiting the right populations into clinical trials,
right,
so that we can not guess at what we think is going to be the best approach. We can define the best approach for this specific population. Do you have recommendations about how we should walk toward that, or any ideas about how SCAI can be more effective in that regard?
The first thing that we need to do is, one, we need to, identify where are these patients who are having the worst outcomes in cardiovascular disease, and who are the treatment teams that are geared to go into these areas. The analogy I use is kind of military analogy. You need to send your SEAL Team 6 guys, the guys who can do the work, meaning go and talk to these patients and explain why it's important to get enrolled into clinical trials. Well, if I walk into a room versus a Caucasian physician here in a predominantly African-American setting at churches or community engagements, well, we all know that majority of people will tend to listen to the African-American. However, it's not just that. It's not just the fact that you're just Black. You have to be technically competent, but the interpersonal connection that you have is something that we just don't teach. We don't teach that now in our training programs. I think we focus more on the science and the technology advancements, but we fail to really delve into why it's important for our minority providers to be not only PIs, but also to go back and be engaged in communities with the backing of organizations like SCAI, where we can come in and form that communal event and publicize it.
I think we could easily spend the entire hour trying to drill down on that, but I'm going to ask you to hold your thoughts. And we can hopefully have a bit of time at the end of the program. We can poke at that a little further, because I'm really eager to learn. But I do want to not fall too far behind on the agenda, so I'm going to introduce Wayne Batchelor at this time, who's going to be talking about heart valve work and disparities. And Wayne, I'm looking forward to your comments very much. The podium is yours.
Well, thank you, Kirk. And first of all, congratulations to Cindy and SCAI under her leadership for putting on this webinar. I think there was a question posed before as to what can SCAI do. And in my opinion, what SCAI can do most effectively is set the example. I think we can lead by example, and by putting on this webinar, by discussing these issues, bringing forth the stakeholders that are so important in changing things over time, including industry, academics, clinicians, the FDA and others. I think that's how we end up changing the future. So I would just put forth to Cindy and Kirk and others at SCAI, the best thing we can do is just do the best job that we can do within SCAI. And that's probably going to serve the rest of the community, and then get the word out there that that's the example that should be set. FOLUSO, thank you so much for that talk. That was just really heartfelt. And I think that's the first time I've actually seen a talk where a physician speaking from a position of purpose, commitment, expertise, research, and public policy all in the same talk. You covered it all. I mean, you're doing all of that. You're really shaping the way that we look at amputations in this country, from the patient bedside to downtown Washington, D.C. So I commend you on that, and I know your purpose is real, and I think your comments on in answering Kirk's questions were very, very well presented and germane. So I'm going to move on now to my talk, and this is on heart valve procedures and disparities. So, I guess the question is, why might treatment disparities even matter when it relates to, for example, transcatheter aortic valve replacement? Well, we know that Blacks are underrepresented in TAVR by about a 3 to 4-fold degree relative to their prevalence in the population. Blacks make up about 14% of the US population and about 3.8% of TAVR procedures. And this has been amazingly consistent over time with very little change. And I'll get into that a little bit later on in my talk. Why the implications of this are pretty stark when you think about the natural history of severe aortic valve stenosis. Inoperable or severe aortic valve stenosis has an abysmal prognosis. Basically, 97% of patients are dead within 5 years. This is worse than just about any metastatic cancer that you can come up with. So the fact that, you know, we've got a treatment gap has real major implications on actual death and morbidity across this country. And if it's left uncorrected, this can translate into a lot of disparity. Now, you know, when we are looking at healthcare disparities, I think David Satcher has done just a wonderful job in quantifying this and putting out actual numbers. What does this actually mean? Well, if you look at standardized mortality ratios between whites and blacks, in 1960, the standardized mortality ratio was 1.47 in blacks versus white. That meant that there was a 47% higher likelihood of dying relative to, in blacks relative to whites. Well, guess what it is in 2000? It's 1.41. It's basically unchanged. So even though we've made some significant strides in the civil rights movement, housing, even economics and education, there still is this huge black-white mortality gap that translates into about 83,000 excess deaths per year among African Americans. Think about that. That's more than strokes, all the strokes in the entire country. It's more than all of the suicides and many other major diseases. So I think we've got a long way to go. And in 40 years, unfortunately, this relative gap has not changed much. So let's just switch gears back to structural heart disease. Well, you know, I think if we're going to embark on a discussion about treatment disparities, we really need to consider who we're referring to and who are the underserved. Who are those groups of patients who don't seem to get the same treatment for some of these novel therapies that have come along in the last decade that have probably been some of the most exciting developments in cardiovascular disease. Well, the American College of Cardiology Interventional Sectional Leadership Council took this on and in conjunction with several others, including Dr. Alusiam Ali in Charlotte. We wrote a paper about this, searching the literature to understand the dynamics around this, and published it last year in JACC. And the factors that we found that appeared to predict underutilization included race, ethnicity, but also simply living in a rural location. So when we frame this question of the underserved, we have to really understand who we're speaking about. And a lot of this is captured by race and ethnicity, social determinants of health. There's this group of the rural patients that we really have to also enter into the arena. And the reason for this is shown here. This is work published by Dr. Damluji, a coworker of mine here at Inova in circulation cardiovascular outcomes just a few months ago. And what he did was he looked at TAVR rates according to population density in Florida from 2011 to 2016. And what he was able to show is whether you're looking at all land in Florida or just the land that excludes the swamp land, there was a 7-fold higher rate of TAVR utilization if you were in a high population density county versus a low population density region. And this correlated with mortality favoring, again, the high population density. 7-fold difference in TAVR. So when we're talking about 2 to 4-fold differences in TAVR based on race and ethnicity, we cannot enter that discussion without considering also where you live is extremely important to whether or not you actually get treated. What are these factors that govern TAVR treatment disparities? And we were able to sort of divide this into 3 major categories. There are patient-related factors that relate to race, ethnicity, the prevalence of disease, symptoms and awareness of disease, access to care, whether you live in a rural versus an urban setting, insurance status, socioeconomic factors, your beliefs, trust of the healthcare system, and life expectancy. Life expectancy shouldn't be ignored. The life expectancy difference between blacks and whites is about 4 to 5 years, and aortic stenosis is a disease of aging. So, all these things can play a role. When you think of healthcare and healthcare system related factors, I've listed them here. This includes treatment biases, diagnostic biases, cultural barriers, and of course, biases that also exist with regards to decisions that are rendered on aortic valve replacement, both surgical and TAVR, where there have been shown to be significant disparities in just simply referring patients and making a decision to intervene on the valve. And then finally, there are disease-related factors, which we really don't have an entire account of. These can, some of these are listed here, and there could be racial differences in some of these factors as well. Now, when we talk about the root determinants of health overall, most contemporary models include basically things around your social environment, genetics, your community and connectivity to the community, education, access to health services, access to healthy food, and your physical environment. And I would submit that most of what determines your health and longevity and access to care is simply governed by your zip code. Zip code covers almost all of this, these sort of determinants of health. So what have we learned so far in terms of studying some of these disparities within the structural heart disease realm? Well, perhaps one of the largest and most informative studies was by Al Cooley and co-authors on this study that was from the TVT Registry. And these authors looked at TAVR rates from 2012 to 2016 based on race and ethnicity. Overall, 91% of all TAVRs in this time frame were in whites, with 4% in Black representation and 3% Hispanic. What's interesting to note is that over the entire time, there was almost no change in these demographics. But luckily, the outcomes were very comparable. Now, if you looked at TAVR versus TMVR, or left atrial appendage closure, there appeared to be treatment gaps between whites, blacks, and Hispanics in all three of these areas. Now, if you looked at outcomes, and I'm just going to flash through these quickly, whether you look at death, stroke, pacemaker, vascular complications, et cetera, then the good news was there was absolutely no difference in outcomes across both race and ethnicity. So this just suggests that we're probably undertreating, but we're not undertreating because of differences in outcome. We're undertreating because of other factors. A more contemporary view of this was a paper that came out by Matt Brennan and at Duke and other co-authors shown here. And they looked at the racial differences in the use of aortic valve replacement for symptomatic severe aortic valve stenosis. The way that they got at this was through natural language processing, examining electronic health records in the Optum database. This is a database that includes a bunch of electronic health records that are put together in a repository from which we can study these various factors. And they looked at a decade of data, 32,000 patients with newly diagnosed untreated severe aortic stenosis. You can see the demographic breakdown here. And then they looked at the rates of TAVR and SAVR and mortality within the year after being diagnosed with untreated severe symptomatic aortic valve stenosis. You can see over here in this upper panel, these are the TAVR and SAVR rates and trends over time. From 2011 to 2016, you can see TAVR shown here in the light bar ended up surpassing SAVR by 2016. Interestingly, if you look at non-Hispanic blacks versus non-Hispanic whites, there was an increase in the numbers of these procedures in both of these categories. So there wasn't really much of a difference in the rate of rise. It's just numerically, there were fewer procedures done in blacks versus whites. And when you tried to account for this through an adjusted odds ratio, so this plugged into the model all sorts of patient characteristics, other healthcare status and healthcare insurance, various other factors. There was about a 30% lower likelihood of you getting any form of aortic valve replacement, whether it's TAVR or SAVR, if you were simply black versus white, and all other factors were accounted for. In that study, the interesting other aspect was if you looked at treated patients versus untreated patients, who were in this study registry, there was no difference in outcome between blacks and whites. So there's a treatment gap whereby the adjusted likelihood of getting TAVR or SAVR was 30% less if you were black versus white, but no difference in outcome. And that's a theme that I think we're seeing across multiple different studies. And if we look at the most recent TMVR trends, we're seeing a slightly different trend, and it's unclear because we don't know the prevalence of disease. But if you look at the TVT registry, 9% of all TMVRs are in blacks, and about for Hispanics, it's about 6%. That's versus 4% of the population of TAVR patients being black. And the question is, are we doing a better job with mitral valve repair, or is it just that the prevalence of disease is higher? So moving forward, I think the bottom line here is, I'll summarize by saying there are treatment gaps that exist for multiple structural heart disease interventions. This might impact mortality and morbidity. The gaps appear to be very clear for TAVR, but less well studied in TMVR, both mitral valve repair and replacement. It's possible that some of these gaps could be attenuating over time based on the most recent data. And our future efforts are going to have to really look at increasing awareness, engaging multiple stakeholders, understanding more about disease prevalence, and better delineating the predictors of undertreatment and the interventions that work to reduce these gaps. And I would submit to say that SCAI, the ACC, the TVT registry, FDA, NIH, industry partners, and public policy makers are all key stakeholders in this effort and are going to be central to moving the ball forward.
Thanks so much. A very erudite and clear presentation. We're running badly behind time, but I do want to give an opportunity for people to ask questions if they remain on the line. I'll report one question out, and then I'm going to hand it over to you, Cindy, to run the discussion period from this point on. Shay Freeman would like to know what role medical device companies should play when they're looking to actively address healthcare inequities and to drive meaningful change.
Is that an open question, Kirk, for the panel? If so, I'd love to chime in.
Yes, this is open to all speakers.
Okay, good. Well, I think that's a crucial question. So let's just think about the paradigm that exists for moving from the device investigational period to commercial release and adoption in society. The sites that get the research get the technology first. And those sites are able to afford their patients that technology first. And so research sites and the pipeline through which patients access new devices has got to be representative of the US demographic better. So industry, in my opinion, has to go bend over backwards to reach out to the sites that have access to the diverse patients. I had the pleasure of working with ROXANA MEHRAN on a study called the Platinum Diversity Study, and we were co-national PIs, and it was really an insightful project. What we did was we just basically enrolled women and minorities in the coronary stent registry for 9 months and got 1,500 patients enrolled in record time, super fast enrollment. In fact, Boston Scientific says it's the fastest enrolling trial in their history. Well, if you look at the sites in that study, you can predict the nature of the patient population based on the sites. And the sites that were in very diverse areas performed extremely well, enrolled very well, had low protocol deviation rates, and enrolled as fast or faster than other sites. So to me, that tells us that we can do research by reaching out to sites that have access to diverse patients, and including women, minorities, older adults. We can do good quality research and not have loss to follow-up rates that are any higher than anywhere else. So to me, industry's responsibility is to reach out and think outside of the box when undergoing site selection, because the sites determine the makeup of the patients.
I think that's a very excellent point, because we definitely need to. I like the slide that FOLUSO showed, which was yours. It's just shocking how few patients, diverse patients and women are enrolled. One thing I wanted to point out, though, is I think there might be a genetic difference with regard to aortic valve disease. I know friends of mine who take care of Chinese patients tell me that the Chinese patients don't have calcific aortic stenosis. They get bicuspid disease and they get aortic insufficiency, but they don't have senile calcific. And then I recall there's an echo study from Vanderbilt. They screened hundreds of thousands of people and found that the African Americans who underwent echoes was similar to the population, but yet there was a much lower prevalence of aortic stenosis in Blacks compared to whites. So do you think that there might be a genetic difference?
Well, it's an excellent question, Cindy. And so the Vanderbilt study was very informative. And by the way, that study showed no difference in mitral valve disease between Blacks and whites, but a significant difference in aortic valve, in the rate and the prevalence of aortic valve disease. The challenge with the echo studies include the fact that there's a referral bias. So you have to actually get to the echo machine and have someone referring you for an echo to get an echo done. So there's some challenges in interpreting that data, but I would submit that there could be genetic differences, and I think that they really do exist. Another example is if you look at, there's a Brazilian study, a study from Brazil that looked at autopsies, serial autopsies, and they have a very diverse population in Brazil. And in this one study, African Americans who died of other causes, African Brazilians who died of other causes, showed lower rates of bicuspid disease and aortic valve sclerosis and thickening and calcification. So there could be some truth to this, Cindy. However, it does not explain a fourfold difference in TAVR rate.
Right.
So if the differences exist, they might account for modest differences, but we're not talking 4 to 5-fold differences. And so I don't want us to think that that's the reason for the undertreatment. That's only a very, very small piece of it.
I just wanted to also add to that excellent explanation also is that everyone should know, and as everyone knows, that aortic stenosis is a disease of elderly and 50% female. And we're seeing, it's the first time that we actually see a clinical trial that has representation of 50% women. So it's not that I believe that for aortic stenosis, and especially for men, Black men, they would have to live that long. The longevity, their life expectancy is just not long enough to actually develop aortic stenosis. And I think that's another reason why we are not seeing it. But nonetheless, this doesn't explain that the selection bias of who's actually getting imaged and evaluated for aortic stenosis should not be 80% white males when you're looking at the male population, and then basically coming down to only 10% of the TVT registry receiving a TAVR. I think it's a mixed bag, as you said, and there could be a genetic issue, but I think you also have to live long enough to get aortic stenosis, and unfortunately our Black males do not.
Right. And then FOLUSO, I just have a question on, have you noticed any difference in the pattern of peripheral disease in Blacks versus whites? Is it more diffuse, more calcific? Is there anything that you think disease-wise might make them more prone for amputations?
Well, what we've seen here, in terms of and some of the data that's been out there, looking at a practice like mine that's 80% predominantly African American, I can tell you that it's not necessarily these patients have some genetic difference in terms of their disease length or in terms of multi-level BTK disease versus above the knee. What you're seeing is that most of these patients are diabetics, high blood pressure, chronic kidney disease patients who come in with basically, either the mid to late stages of their cancer. That's the analogy I utilize, right? And the reason is because most of them reside in poor rural areas where majority of the practitioners that take care of them are either nurse practitioners, all right? And most of these nurse practitioners are just not familiar with screening for PAD or identifying those risk factors. And so when we came in and we started educating the nurse practitioners and their teams, we found out that most of these patients now were being identified early on and given a chance to being started on their statin therapy, their antiplatelet therapy. Supervised exercise therapy became, in play now, right? And so it's given a chance, a fighter's chance to catch that disease early on. And for those that we don't catch early on, it's also what's the technical capability that's available here in rural Mississippi for a provider to treat very challenging below the knee disease. It's the technical competence. So the training of the physician also plays a role, and they'd be able to identify and treat those, tough lesions, and knowing when to send a patient for bypass versus minimally invasive procedures. So it's, women, the women that we see have more, they present more with severe ischemia. They present more late stage. I just feel like they're ignored. Just the plain and simple, ignored. It's arthritis, it's gout, it's 100 things before it's identified as PAD, and when it's identified as PAD, they're critical limb ischemia, Rutherford stage 5, 6.
Mm-hmm. Okay, one last question from the audience, and anybody can take this. Are there specific cultural barriers to getting minorities to participate in research, especially due to the mistrust of medical community?
Yeah, I mean, that is a historical gap that actually preceded. If you go back to even the use or the lack thereof of anesthesia being used for gynecological or obstetric care during slavery years, to Tuskegee, to HELA cells, to there are just a bunch of historical context where in the African American community there's been this historical mistrust. So that's gaps in terms of trying to engage these communities and reassure them. I mean, we're seeing that even with COVID trials. They're very challenging in terms of recruiting minorities.
Mm-hmm.
It's just because we have failed to address this issue in our healthcare system.
But how can we address it? Any idea?
First, we have to identify, and we have to raise that awareness to our colleagues in training that there is systemic racism that has occurred in healthcare, and these are some of the reasons why they exist. And we need to be sensitive to these patient populations when we try and engage them in enrolling them in certain trials. And you need a coalition to help you identify how best to approach that patient population. You can't just blindly use the same words. And this is something I've learned down here. You can't just go to every trial and ask a patient, do you smoke? You know why? In the African American community, for instance, breaking news, most African Americans don't smoke. Do you know what they do? They dip or they chew nicotine. So if you don't consider that and you're saying, hey, do you smoke? Most people will tell you no. Well, you just missed a whole risk stratification right there. And that's common in the South.
Wow.
So that's just an example. Things that you have to be common knowledge of understanding the cultural competency of the team that's engaged in that community and how to engender their trust.
Mm-hmm. And any ideas from the panel about Hispanics? How to better engage them?
Yeah,
I think language barrier is a very, very important one, and that when we have a lot of Hispanic patients, and in Platinum Diversity we enrolled many, and we have immediately, as soon as we get a research trial in our institution, we ask for a Spanish consent, 100%, because we want to have. And 2 of our coordinators are fluent in Spanish. So they will go with the doctor and they do full translation of the documents and are able to talk with them. And then family members are extremely important in the Hispanic community, engaging the family. Much like FOLUSO knows in the African American community, you saw what happened in the barbershop study. If you go to their community in a trusted area where the physician and the caretakers are there in a community setting, whether it's a church or a cultural center, then you're able to enroll those patients. And I think it's similar for the Spanish patients.
Mhm.
I
Okay,
think those are,
I think we're at the top of the hour, aren't we, Kirk?
well, yeah, I was going to say though that I'm staggered by the quality of this conversation. I mean, we say, gee, it's a great conversation at every meeting, but truly, this has really been deep and insightful. But we are running well over the hour. I think to respect the time of our attendees, we should call it a wrap. I do want to thank all of our stellar speakers for making time this evening, giving of their time in order to connect with all of you. I hope you've enjoyed this program. If you have any comments, please use the SCAI link to report back to us. We strive to improve. We're a learning organization and we would like to hear your feedback. With that, Cindy, I'll turn it to you for a final comment.
Okay, and I would just like to thank Medtronic for their very generous support of this extremely important webinar. Thank you so much.
Thanks, everyone.
Bye, everybody.
Thank you. Bye, everyone.
Thank you, everyone. Have a good night and a happy Thanksgiving.
Be
Stay safe.
Bye-bye.